connecting with your body. So a little bit about me. I am an assistant professor at UNC Charlotte in the counseling department. I specialize in addiction and mental health counseling. I've also been a clinician as a counselor for about 7 years. And this is having worked with a number of clients who were coming to me with substance use disorders and addictions, but also had a history of trauma, especially sexually related trauma. This is something that I have seen a number of times in my clinical work. I often talk about it with my students, and I just think it's a really important topic. A few housekeeping items before I get started. If you could save all your questions to the end, I'll happily answer them. But we have a lot of information to get through in the next hour. I will also say this is my work from home day, so I'm at my house, and I have a cat who may insist on being a part of this training. And so I will just like give that disclaimer. I would kick her out, but she would just sit outside the door and scream the whole time. So you may see her walking about at some point. But with all that, let's go ahead and get started. So today, we'll work together to explore the complex relationship between sexual trauma and substance use with the goal of understanding how substances impact the body and the mind. We'll talk about the mental health impact. We'll talk about how the brain is really a major part in both the trauma processing and long-term impacts of trauma, as well as the person's psychological and emotional pieces, how those can impact both trauma and how trauma can impact that as well as substance use. And then we'll also learn, like I said, about the impact of trauma and the physiological effects of substance use and ways to reconnect the body through grounding techniques. And if we have some time at the end, I'll lead us through a very brief grounding technique so that way you guys can start to use it with some of the folks that you advocate on behalf of and some of your clients. So let's first start by talking about the impact of trauma. And so a big question, does sexual trauma always lead to an addiction or substance use? And not necessarily. There are certainly many, many people who have been survivors of sexual trauma or any types of trauma and do not develop a substance use disorder or an addiction. That said, research has found that out of 600 people with a substance use disorder, more than half reported being survivors of physical or sexual abuse. And I'm going to go out on a limb and say that more than half figure is very, very low. I'm going to go out on a limb and say it's really much higher. As you probably know, sexual trauma and things like sexual assault and rape are heavily underreported, even in 2025, the year that we're living in. And then childhood history of sexual abuse can result in a 73% greater risk of developing a substance use disorder or an addiction within that person's lifetime. And physical abuse survivors, in comparison, have a 74% greater risk. So really, the impact of sexual trauma at any point in the life, it doesn't need to happen when one is a young adult in college. It can happen when you're very young. It can happen when you're quite older. Sexual trauma at any point in the lifetime can lead to an addiction or severe substance use much later on. So let's talk about the types of trauma. So there are 3 types. These are certainly not the only types of trauma, but they're really the ones that are the most relevant for this topic. And the first one is acute trauma. And this is the result of a single stressful or dangerous event. This, for example, could be one instance of sexual assault or rape, one instant, just one thing that happens. It can be, for example, a stranger rape or an acquaintance rape or assault, but it is one isolated, but still very dangerous and stressful incident. Chronic trauma is the result of repeated and prolonged exposure to highly stressful and traumatic events. So examples could include a history of child sexual abuse or domestic violence. This is not a one-off or acute event. This is a history of the typically multiple of the same events, and also typically perpetrated by the same individual or individuals. And then there's complex trauma, and this is the results from exposure to multiple traumatic events. Now, if you don't already know, a survivor of one type of sexual trauma, say rape or sexual assault, has an increased risk of being raped or sexually assaulted or experiencing some other type of sexual trauma later in life, simply because they experienced that one event. They now have a higher risk of experiencing future similar events. This is where complex trauma can come in. Say that someone has a history of child sexual abuse. As they get older, that is chronic trauma, but as they get older, they now are the survivor of sexual assault during college. That would be complex trauma. It's multiple separate events, and that are not necessarily connected, that are not necessarily perpetrated by the same person or persons. And that happens typically across a longer period of time. And yes, thank you, Yenting. If you have any questions and prefer to remain anonymous, you can put them, you can send them to Yenting and she will relay them to me. So individual experiences of sexual trauma all depend on how a person is dealing, what their coping skills are, things like personal characteristics, things like the presence of other mental health conditions. If somebody is already experiencing depression or anxiety or bipolar disorder, and then they're survivor of sexual trauma, those existing mental health conditions may exacerbate how they process their trauma, may exacerbate the symptoms of trauma and PTSD. You also want to consider current substance use or misuse, and we'll get into this a little bit more later. But if somebody already has an addiction, maybe they don't have a history of sexual trauma, they may have a history of other types of trauma, such as neglect, physical abuse, things like that, but they don't have a history of sexual trauma. And they have been using substances to cope with those symptoms of trauma. And then they have a sexual trauma, and they're the survivor of that. That can obviously impact how they process that trauma, how the PTSD is potentially treated, and it can just really make their substance use a lot worse. And like I said, we'll talk about that in just a little bit. You also want to consider if they've had previous exposure to other traumatic events, sexual or non-sexual. And the type and characteristic of the event or events, was it acute trauma where it is a singular, very severe event? Is it chronic and it's been happening over a number of years? And then you also want to consider the individual person's background and approach to handling emotions. Were they emotionally stable prior to this event? Did they have a lot of coping skills? Did they have a support system in place? Those kind of preventative measures, having good coping skills, being emotionally stable, having a support system, can really, really make a difference in how this person goes about processing their trauma, how they go about, and how you can work with other providers to treat it. Now, when we think about any type of trauma, but this is highly relevant with sexual trauma, we always want to think about the fight, flight, freeze, fawn response. You might have heard of the fight, flight, freeze. You've probably heard of fight, flight for sure. But there's another one that's been coming up in the research that people have kind of been denoting as fawn. And that is essentially when, in order to prevent any severe in order to prevent the situation from getting worse, a survivor might go along with whatever is happening in order to just survive. So when your brain detects a threat, the amygdala initiates a quick and automatic defense. Now, for example, if fight or flight are kind of self-explanatory. Freeze, it might look like almost like your brain is slowing down. That's often how people will describe it to me. They can't think, they can't process information. It's very much like they just froze. There's a release of adrenaline and norepinephrine and glucose to rev up your brain and body into basically having some kind of a reaction. But depending on how you responded within the fight, flight, freeze, fawn, sometimes that response is so delayed that the event is already happening. And it's almost too late to stop it without putting yourself in more danger. So should the threat continue, the amygdala communicates with the hypothalamus and the pituitary gland to release cortisol. And then the prefrontal cortex consciously assesses the threat and either accentuates or calms down the fight, flight, freeze, fawn response. And so I'll get into these brain pieces in a little bit to focus on the physiological impacts of sexual trauma. But that's pretty much just a very brief overview of the fight, flight, freeze response. Essentially, the brain releases certain chemicals in order to have a reaction or a response to the trauma, but sometimes that response can put us in more danger. And it's important to know that the fight, flight, freeze, fawn response is very evolutionary. Realistically, when cavemen were, running away from a tiger, some of these things made more sense. But when we're running away from somebody that might want to harm us, or one of our clients reports that they froze or they didn't want something to happen, but they just went along with it because they didn't know what else to do. They kind of were a fawn in that case. In these situations, our brain is creating a reaction that is first and foremost to keep us alive. It is not necessarily to keep us safe in every context. So I don't want to get too much into the neuroscience here. I myself am not a neuroscientist, but I often think that we cannot talk about trauma and the impact of trauma without talking about the brain. And I'll tell this to my clients. I'll often walk them through this information as well, because I tell them often, we only get one brain, and trauma really compromises our brains. So the amygdala, you'll see it right here, this little reddish orange little spot. It's located within the temporal lobe, and it detects threats and activates the central nervous system fight, flight, freeze, or response. And it helps you restore new emotional or threat-related memories. And so I'll talk about this a little bit more, but the amygdala, now that it's restoring new emotional or threat-related memories, this is where we often see people become very hyper-aroused or hyper-vigilant because they're often remembering. The prefrontal cortex is kind of right at the front of our brain, right here. It's located in that frontal lobe just behind your forehead, and it allows you to think through cause and effect, make plans, recognize potential consequences, and moderate our social behavior. And I will say these two, like the amygdala, the prefrontal cortex, and this slide on the hippocampus, is in a functioning brain. Like, this is the ideal situation. I'll show you what it traumatized, how these are all impacted after trauma. And the hippocampus is responsible for memory, recording new memories and retrieving them later, and then distinguishing between past and present memories. So, how trauma changes the brain, and how might this be important to consider in addiction and trauma treatment? So, post-trauma, researchers and neuroscientists have found that after a traumatic event, individuals and survivors will have a hyperactive amygdala, a less activated prefrontal cortex, and an impairment in hippocampus functioning. So let's talk about a hyperactive amygdala really quick. So the amygdala, again, it detects threats or perceived threats. So not necessarily real threats, but it could be perceived threats, and activates that fight, flight, freeze, fawn response. And so if you have a very hyperactive amygdala, this is where we often will see people, for example, a veteran who's used to hearing gunfire and hitting the floor. Now they're, in their back home and they hear a car backfire. They're not in any danger, but they perceive that threat of danger. So they hit the floor, even if there's no danger, even if everything is fine, and everyone around them knows that it wasn't gunfire, it was a car backfiring. Same thing with individuals who have experienced a sexual trauma. They might find themselves in a similar situation or a similarly perceived situation. Maybe they walk down, maybe they walk in the same area of where they had been assaulted, or maybe somebody makes a comment about their looks or about their appearance, and they have that fight, flight, freeze, fawn response, even though they're not in any active danger. A less activated prefrontal cortex. So again, the prefrontal cortex allows us to think through cause and effect, make plans, recognize consequences, and then moderate our behavior. If that prefrontal cortex is no longer working, we can't plan. We can't recognize potential consequences. We can't think through cause and effect. Many of you have probably seen instances of individuals who are survivors of sexual trauma who now have a hard time making decisions. They may even make pretty irrational decisions where it leaves you thinking, why did you do that? What was the reason? Like, there's no way that this would have ever worked out well. And it didn't. But because the prefrontal cortex is no longer working in the way that it's supposed to, it's no longer allowing someone to think through cause and effect and recognize potential consequences of their actions, they start to make decisions that don't seemingly make a whole lot of sense on the surface level or to other people. This is where we will often see someone who has left domestic violence or toxic relationship go back to their partner. Even if they are not financially dependent on them, even if their friends are telling them, don't go back, you have to stay, like, come live with us, you can't go back to them. And they still do. They might not be able to make the same rational decisions that they could prior to experiencing that chronic trauma. And then an impaired hippocampus. Again, the hippocampus is responsible for making memories, recording new memories and retrieving them later, and distinguishing between past and present memories. And so this is where we can sometimes see people who are survivors of sexual trauma have difficulty telling the difference between a past and the current events. This is where we might even see them have flashbacks or night terrors. It's part of the hippocampus because it's harder to differentiate between what is actually happening and then being safe in this moment and then remembering their past trauma where they were not safe. So I also want to point out, so these are the trauma changes in the brain. It also involves hyperarousal. So because the amygdala is overactive and more norepinephrine is released in response to perceived and real threats, and it's not released in a well-regulated prefrontal cortex, it causes hyperarousal. So norepinephrine releases energy. It helps us respond to different situations in a very quick fashion where we don't necessarily have to think about it too hard. But when norepinephrine is constantly being released and released and released, when it normally isn't, this causes excessive hyperarousal, hypervigilance, and an increased wakefulness and sleep disruption. People who have reported sexual trauma will say that they feel like they're always on edge. They feel like they're walking on eggshells. They're always looking around the corner or looking behind them. They're always perceiving a threat. And then they're also not sleeping very well. They may go for multiple days without sleeping well. They're constantly waking up at the slightest little sound, or they feel like if they sleep, something bad is going to happen, or they'll have night terrors. And so I want us to all put ourselves in this situation for just a minute and think about, okay, if we're so hyper aroused, if we're always hyper vigilant and perceiving threats, and we're not sleeping, that is extremely difficult and traumatic in and of itself. And so we're not processing our previous trauma that we survived. We're living in the moment every single day, just trying to survive this moment because it's so exhausting. There's also a number of emotional and psychological responses to trauma, such as denial, anger, fear, sadness, shame, confusion, anxiety, depression, numbness, guilt, hopelessness, irritability, difficulty concentrating, having flashbacks, and emotional outbursts. I often feel like media presents PTSD and response to trauma as like almost exclusively flashbacks. um, and that's not necessarily it. I often will tell clients, feel free to ask, or I'll often tell students, feel free to ask clients about flashbacks or night terrors. But if they don't report those, that doesn't necessarily mean that they don't have a history of trauma. I once had a client who very heartbreaking situation. She described in detail, like in really specific detail, how she was raped when she was 13. But as she was talking about it, she was completely numb, completely blank and flat affect, having no emotional reaction or response as she's telling me this. And I'm having more of an emotional response as she's talking to me, but she's having none. And so keep in mind that a client or a person, a survivor, may experience one or two or all of these things. It's certainly not just going to be flashbacks or what it looks like in movies and TV shows. There's also an increased fear and anger and a decreased positive emotionality. And so in individuals who are survivors of sexual trauma, they have an excess of negative emotion and little positive emotion. They'll often feel like the things that they enjoyed doing previously prior to the trauma, they can't enjoy those anymore. They don't have as much fun talking to friends and having social interactions. They also have difficulty assigning meaning to events. Now, most clients probably won't be able to say this specifically. They probably won't say like, I'm having difficulty assigning meaning to important events. But instead, if they did, I'd actually be very impressed. Instead, they'll typically say, yeah, like I went, my friends threw me a birthday party and it was nice, but like, I don't know, it was fine. But like, imagine in a typical person, if friends threw you a birthday party, that'd be such a wonderful and meaningful experience. But in a person who has survived sexual trauma, they won't assign that same meaning to it. They may even have a really negative perspective of like, why would they do that? They know I'm busy. I can't handle this right now. I know they meant well. And it's hard to sometimes hear that as someone who, maybe hasn't survived a sexual trauma, of like, well, why aren't you just happy? Why aren't you grateful? But it's because of this change in their brain. It's very difficult to assign positive meaning to events and have positive emotionality. And they also have a lot of challenges to regulate negative emotions and make rational decisions. And so this is where we'll often see survivors make what we would consider maybe very poor decisions or irrational decisions. And we'll talk about how this relates back to substance use in just a little bit. But for right now, I want to think about, individuals who are already using or abusing substances are also typically not making the best choices for themselves or, putting themselves in the safest environments and situations. And so there's a lot of difficulty making rational decisions and good choices. There's a number of physical responses to trauma as well. These can look like headaches, digestive symptoms, fatigue, racing heart, sweating, feeling jumpy. These or any others can look like panic attacks, if some of them are combined, but you might also see some of these individually. I've certainly had clients that started complaining about headaches and migraines after experiencing a traumatic event. And they said, before this, I never had any migraines. I never had any headaches. And it's one of those physical responses to the trauma. And I mentioned impulsivity before. So it's really important to know that impulsivity typically will increase in somebody that has experienced a sexual trauma. They're often alert and ready for quick action when they face a threat, and this leads them to be more impulsive. And like I said, there's that less active prefrontal cortex to regulate impulsive actions. And so they typically don't regulate them. They make very potentially dangerous impulsive decisions. Maybe they decide to, end friendships from people that were really supportive of them and were really trying, but they were like, they say, I'm sorry if you heard my cat feeder go off. They might say, they were just getting too much in my business. I just couldn't handle it anymore. They were always texting and asking if I'm okay. And I am okay. Like, I don't know what they're worried about. Like they start to make these very impulsive decisions. Or they may say, I once had a situation where I had a client who was pretty violently raped, and we're talking about it. We're working together, I think twice a week at that point, where I'm helping her process much of what happened. And all of a sudden, I think 2 months into treatment, this is probably 3 months after the rape that she survived, she says, like, I got a new boyfriend. We're moving in next week. I'm like, oh, okay. What? It's these sorts of impulsive decisions that a typical person likely would not make because their prefrontal cortex would be able to regulate their impulsive actions. And then there's less control over those impulsive behaviors, especially when they're emotionally triggered. And so you see that heightened response in impulsivity when somebody is already very emotional and emotionally triggered. So let's talk about the physiological and otherwise effects of substance use. So before we do that, I want to point out, so everything that we've talked about so far with the impact of trauma on the brain, on emotions, physically, on impulsivity, that is with somebody who has experienced a sexually traumatic event, but is not using substances. So imagine that. This is all happening, and we have not addressed substance use yet. Substance use is not entered into this person just yet. And so they're already hyper alert, impulsive, hyper vigilant. They're not sleeping. They're experiencing a wide array of emotions. They're having headaches. Their stomach hurts. They're feeling really jumpy and on edge all the time. And then you throw in substance use. Sexual trauma, and as well as extremely stressful experiences, make a person much more vulnerable to developing a substance use disorder or addiction. Sexual trauma may cause clients or patients to start self-medicating using substances. So imagine you're not sleeping. You haven't had a full night's sleep in weeks. You start drinking at night to go to bed. And it kind of helps, but it's not helping enough. So you start drinking more every night. And then you start drinking more and more until you basically make yourself pass out. But then you're sleeping through the night. So you wake up hungover, but you at least slept and you didn't have any nightmares and you didn't have any flashbacks. And so people will often use substances to self-medicate with both the emotional and the physical symptoms of trauma. It can help them temporarily cope with their distress, and it can ease or alleviate their mental health symptoms in the short term. Central nervous system depressants such as alcohol and benzodiazepines will slow down that central nervous system. Depressants are not going to necessarily make you depressed. They're called depressants because they slow down our central nervous system and our processing in the brain. And so if our central nervous system is slowed down, we're less hyperactive, we're less hyperaroused, and we're typically able to sleep. Substance use, misuse, or abuse has a range of health-related impacts, and these can include risk of liver damage, heart disease, stroke, and lung disease. And that is just in a person who is just misusing or abusing substances. We're not, again, they might not even have a history of sexual trauma and all of the hyperarousal and all of the brain changes and everything like that, and they're still at a higher risk of liver damage, heart disease, stroke, and lung disease. Substance use, misuse, and abuse will also impact one's mental health and ability to process information. It can exacerbate existing mental health disorders such as anxiety, depression, and PTSD, and it can even cause psychosis and cognitive impairment. So again, this is just substance use. We have not yet combined substance use and trauma yet, the impacts of substance use and trauma. But let's go ahead and do that. So again, I'm not going to get too much into the neuroscience here, but you might notice that some of the neurological impacts, some of the parts of our brain that were deeply impacted by a traumatic event are also being deeply impacted by substance use. So there is something called the stages of the addiction cycle, and it happens emotionally, it happens socially, but it also happens neurologically within our brains. And the first stage is the binge and intoxication cycle that takes place in the basal ganglia. It reinforces substance use and changes how a person responds to future potential traumatic events. And so think about that. If somebody who already had, who was already misusing substances, who didn't necessarily have a history of sexual trauma, but they're already abusing substances, they already have an addiction, that now that they have that addiction, now that they've gone through the binge and intoxication stage, if they experience a traumatic event in the future, they're absolutely, they're much more likely to perceive it differently. They're not going to respond to that traumatic event in the same way that they would had they not been abusing substances already. The binge and intoxication stage also affects the reward systems of the brain. So it will increase the rewarded effects of the substances. It will reduce anxiety, depression, and hyperarousal in people that have already experienced that are already experiencing a traumatic response. So as I said before, someone who has just experienced a traumatic event, they're hyperarousal, they're hypervigilant, they're not sleeping very well. Substances will often reduce all of that, and they'll also reduce their general anxiety and depression and alleviate some of their emotional reactions to the trauma. They won't feel as confused, they won't feel as much guilt. They just might not feel anything at all, but that's better than feeling what they did. The next stage is the negative effect, or with the withdrawal stage, which it happens in that amygdala, like we talked about before, that is also affected and impacted by trauma. So someone will experience physical and emotional symptoms of withdrawal and detoxification, which, if you haven't already heard, the experience, depending on the substance, the experiences of withdrawal and detox can range from feeling the worst that somebody has ever felt in their entire life to death. And it will kind of happen somewhere within that range. So then the person will begin using substances to avoid those negative impacts of withdrawal and detoxification, and they'll continue using substances to avoid these negative emotions and feelings before. If they were able to sleep because they were drinking a bottle of wine every single night, well, they're sleeping, so they're not waking up every hour every time they hear a slight little noise. They're not as stressed because they're constantly hyperaroused and hypervigilant. And so there's a negative effect of withdrawing, so they choose to continue using the substance to avoid withdrawal and avoid the negative feelings associated with the trauma. And that's really where the self-medication comes in. And then finally, there's the preoccupation and the anticipation stage, which happens again in that prefrontal cortex, which has already been compromised and less active because of the trauma. In this stage, people continue to seek substances after periods of abstinence, because during those periods of abstinence, they go through the really negative impacts of withdrawal and detoxification. And then they also experience those negative emotions related to the trauma. They go back to being hypervigilant and hyperaroused. They have nightmares. They can't sleep very well. They feel miserable about themselves. They're really depressed and anxious. And so they continue to use substances because it's better than feeling how they felt before. And they have this will develop into a constant and preoccupied thinking toward using substances, unbearable cravings, and those acts of impulsivity. Like I said, people who are using or abusing substances are typically pretty impulsive because the substance use in and of itself is affecting that prefrontal cortex, that ability that part of the brain that makes rational decisions. The trauma also impacted it too, so it's basically kind of a double whammy. The prefrontal cortex is really not able to regulate impulsivity and make good choices. And if you look at people who have a history of both surviving sexual trauma and have either a past substance use disorder or an active addiction, they're typically not making good choices. They might live with their dealer. They might solicit themselves because that's how they can afford substances. That's how they can get high. And so they're putting themselves in these really potentially dangerous situations, and they're potentially being really impulsive about it. And when we look at the stages of the addiction cycle, and we look at how addiction and trauma both drastically impact the brain and impact the brain's functioning, one thing that I always want people to remember is people use substances to change how they feel. Anything is theoretically possible, but I'm going to go out on a limb and say that nobody like wakes up one day and decides, I'm going to use meth when they've had no history of trauma and no history of addiction in the past. A typical person doesn't wake up and have those kind of very impulsive, pretty dangerous thoughts. But somebody who has experienced trauma, somebody who has an addiction or an addiction history already, will not be able to regulate those impulsive thoughts. And they also probably really want to change how they feel physically, emotionally, neurologically, what have you. And so people will use substances to always change how they are feeling and alleviate emotional distress. Addiction and relapse are also absolutely impacted by trauma. And so sexual trauma and other traumatic stressors can cause changes to a person's brain functioning and behavior. And this makes it more likely that a typical or average substance use will lead to an addiction. So somebody who has experienced trauma might not be able to just drink socially or drink casually at a party, because for a typical person, maybe they have 2 drinks and then they're done. Somebody who has experienced a history of trauma and even has a history of substance use cannot drink those 2 drinks. It might turn into 5, 6, 7, and then they're passing out. Further adverse childhood experiences such as sexual violence or abuse during childhood is associated with a greater likelihood of developing an addiction later in life. So let's talk a little bit now about what we as helpers and helping professionals can do. Grounding techniques are a really wonderful way to start working with individuals who are both survivors of sexual trauma and have a history of substance use and abuse, or maybe trying to go through the detoxification process. So grounding techniques allow clients, patients, and those that we're advocating on behalf of to focus on the here and now instead of the there and then. As I said, individuals who have a history of trauma have a really hard time differentiating between past and present events. And so they're often preoccupied with past events. And so when we use grounding, we're asking them, hey, don't think about that. That's not happening to you right now. I want you to think about what is happening to you in this moment and be more focused on the present. Grounding techniques can also serve as a distraction during really overwhelming and distressing situations. These can include substance cravings. Substance cravings are extremely distressing, and it often will require teaching people some level of grounding techniques so that they can do something called urge surfing, which is basically sitting in the present, recognizing that these cravings, these urges will pass, but they have to wait and work through them in order to get to that point where they no longer experience them. They can also be helpful in situations where a person may be having unwanted or uncontrolled memories that keep coming up, or flashbacks. And they can also really help if somebody is experiencing a panic attack. All grounding techniques have one common goal, which is returning focus to the present moment and reconnecting the person with the mind, reconnecting the mind with the body. So one example that you may have heard of, I really love this technique. It's called the 5-4-3-2-1 technique. What you will want to start doing is put clients in, just ask them to kind of sit back, relax in their chair or wherever you're working with them, put their feet on the ground, relax their shoulders, because everyone I feel like always sits like this, like with their shoulders right up to their ear. You want to make sure that their shoulders are down and back. And then you want to ask that once you get a sense that they feel relaxed, you can ask them, tell me 5 things that you see. Don't move around your head too much. You could look around the room a little bit, but don't, like look behind you or anything like that. But just looking right ahead, what are 5 things that you can see? They can list those 5 things off and then ask them to close their eyes. Now, make sure that make sure that they're okay with closing their eyes. Many people who have a history of sexual trauma or any kind of trauma might feel a lot of hypervigilance toward closing their eyes and some fear and anxiety toward that. So make sure that they're okay with it, that they're consenting to that, and remind them, this is a safe space. And if you start to have a reaction, I will guide you through that and I will be here for you. But when they close their eyes, you can say, tell me 4 things that you can hear. And I always get so surprised. Like people will often, they'll say the more immediate things first. Like if we're outside, they'll say like, I can hear birds, I can hear the wind blowing. But then they'll say, I can hear like a bug way back there. I can hear construction super far off. They'll start to hear things that you wouldn't necessarily be able to hear and process if your eyes were open, if you're focused on other things. I'm sorry, 4 things that you can feel, 3 things that you can hear. The 4 things you can feel, what can they feel? Can they feel their arms on an armrest? Can they feel their back against the chair? Maybe they can feel their feet onto the floor. And then 2 things that they can smell. This might be like they can smell. I always would have like a candle in my office, so they would often tell me they smell that. And then one thing that they can taste. You can choose whether or not to do the taste. I've done it before. I usually will have like mints or a Jolly Rancher that I'll ask them to kind of pop in their mouth, and then they'll tell me about that taste. But you also want to make sure that your client is okay with receiving any kind of food. And if they have any, potential dietary preferences. For example, if somebody was pre-diabetic, I wouldn't give them a Jolly Rancher. I might ask like, what's something else that you could have? There's lots of other grounding techniques. There's mental grounding techniques and physical grounding techniques. So mental grounding techniques include the memory game. So you'll often have a very busy picture in front of you that you'll give a client. They'll ask them to study that busy picture for about 10 seconds and then have them turn it face down and then try to recreate it in their mind or list off everything about the picture. So I'll sometimes ask them to even close their eyes and say, tell me everything that was in that picture. You can also use anchoring phrases. This, for example, could include some kind of statement like, I am Natalie Ricciutti. I am 31 years old. I live in Charlotte, North Carolina. It's 7 p.m. on Thursday, January 14th, whatever. And I am sitting at my desk. I am reading. You can ask them to continue that narrative. What's the weather like? What are their surroundings? Are there any pets nearby? What's in the room with them? Things like that, until they start to feel calm. And then guided imagery. This is a really wonderful practice. In the references, I have a link to a script that you can use, but it's essentially asking your client, getting them into that relaxed state, closing their eyes, and then inviting them to have some visual mental imagery where you're guiding them through visualizing, placing all of their negative emotions in a box, and then putting that box on a high shelf. Or I've also seen it where they put that box in a safe or a locked chest, or however, that has a bunch of chains around it, however they want to visualize it. And then walking away from those painful feelings that are in the box. Those feelings are still there, but they don't need to be affected by them every single day. And what I would often use this one specifically for clients that had a history of trauma, I would do this with them early on in treatment. And then in treatment, at the very beginning of future sessions, I would say, all right, let's go through the process of guided imagery again. You unlock the box, you take the box out, we open the box, and then we deal with all of the negative emotions in session. Or you can pick and choose which negative emotions to deal with in every session. And then you end the session by having them put everything back in the box and then putting the box back on the shelf or in the chest or in the safe or what have you. This one's really helpful. Like I said, in the references, I have a link to a script that you can use with clients that is really, really beneficial. I've used it a ton of times. It's super, super helpful for clients that have a history of trauma. Other grounding techniques can be physical. So this includes deep breathing or meditation. I always tell clients, focus on the air going in and out of your lungs. And as thoughts and emotions come up, work to really acknowledge them and then let them pass. You acknowledge them like, I am aware that I'm having this reaction, or I'm aware that this thought just occurred to me, but I'm not going to focus on that right now. And I often will tell clients to imagine that they're almost pushing it away. You can also ask clients to place their hands into maybe a bucket or a bowl of water, and then have them focus on the temperature and the sensation of the water. I've seen this used with both a hot and a cold bowl of water, where they start maybe with the cold bowl of water, and then they move their hands to the warm bowl of water. Don't make it too hot or too cold. And then they move back and forth, and you can ask them, like, what are the different sensations? And having them just focus on the sensations of their hands being in the water and on the temperature of the water until they can start to calm down a little bit. I'll skip the next one because I can model that for you all. But the last one is moving your body. Sometimes if I can tell a client is having a really strong emotional reaction, or they're getting tense, or I sense that they might be starting to have a panic attack, I might say, let's just stand up and let's just kind of like swing our arms, which sounds very silly, but doing any kind of simple movements, like just kind of twisting around, or having little simple exercises like jumping jacks or jogging in place, that can usually re-regulate the body and the mind. People who exercise regularly will often say that it really helps them cope with negative emotions because they almost can't experience those negative emotions while being physically active. And so that is something that you can just do really quickly when you're talking to a group of people or even just one person of like, let's just get up and let's just it's going to be weird, but just do some jumping jacks. Like it's always a little odd, but it will help them. It will help their mind almost like reset, and it will help them become more emotionally regulated. The last one that I said I wanted for us, I can show you guys to do now is pressing your feet into the floor. And so what I'd like you to do for this one, if all of you, some of you don't have your cameras on, so I will just assume that you're doing this. Go ahead and sit back in your chair or wherever you're sitting in and make sure your feet are fully touching the floor. If you are like me and you're really short and you have to like sit forward on your chair a little bit so that your feet can fully touch the floor, feel free to do that as long as you're comfortable. And then close your eyes and start to focus a little bit more on your breath. And start to just relax your shoulders down and back, but make sure your feet are touching the floor fully. And now I want you to purposely press your feet into the floor, putting energy and weight into your feet, pressing them fully into the floor from the back of the heel to the tips of your toes. And now let that go. You can take the energy out, you can take the weight off. And now try it one more time, pressing those feet into the floor fully. And now let it go. Pressing, doing that, and you can open your eyes if you haven't already. Doing something even just that simple can really encourage your clients or people that you're working with. It can really help them be more present in their physical body while they're talking about really emotionally distressing or painful topics. Whenever I get a sense or whenever I have a plan with a client that I know they're going to want to talk about past trauma or something that is going to be really painful for them, I'll often guide them through that, pressing their feet into the floor before we start getting into some really emotional topics. And I say, if you feel like you're starting to get too emotional or you feel like you might be on the verge of a panic attack, I want you to press your feet into the floor and start to take a few deep breaths. You don't need to, and I'll even say, like, you don't need to tell me that you're doing this. I'll just get a sense of it and I'll let you have your few seconds. But it's really important to encourage people and to use grounding techniques, and I ideally teach them some of these grounding techniques before addressing painful topics, before getting into that as part of their treatment, or as part of any kind of helping techniques that you're doing with them. That way they can work through these, they can use these on their own, both in meetings and sessions with you guys and in their own and outside in their own lives. They have these techniques that they can use forever. So conclusions and things to finally consider. When we think about trauma and addiction, we want to think about we always want to think about that comorbidity, the existence of two things at once when it comes to trauma and addiction. We want to think about the impact of trauma on recovery. Ultimately, the goal of any kind of substance use or addiction treatment is recovery, whether that's completely abstinence-focused recovery, whether it's harm reduction recovery. The goal is always some type of recovery, and trauma can impact that, like we talked about. So we want to think about, how can I help their trauma so that their recovery will be more successful and long-lasting? We also want to think about the chicken or the egg scenario here. What happened first and what caused the other? Did the substance use, did they have that first and that put them in a potentially dangerous situation and then the trauma occurred? Did the trauma happen and they're using substances to self-medicate? Or was there kind of a combination? They may have been already using they may have had a traumatic event, they're using substances to self-medicate, and then they're putting themselves in potentially dangerous situations where they've been re-traumatized, and the substance use just becomes exacerbated. And we want to think about, again, how all of these things might impact relapse prevention, treatment planning, and the modality of treatment. And then finally, grounding techniques can be extremely effective and can allow you to decrease a client's hyperarousal so that treatment can be more effective. These are my references specifically. Where was it? This top one is the guided meditation script. I encourage you guys to use it. I will send my slides here to Yenting. She can send them out to you guys. And that is currently all I have, but what questions can I answer for you?
So we did have a question that came through when we were talking about impulsivity. So the question is, could the seemingly impulsive behaviors be a coping mechanism?
They could. It depends on what those impulsive behaviors are, but they absolutely could be considered a coping mechanism. I often will think of like, um, you know, I don't love this example, but cutting is a really impulsive decision, but for some people that can be a coping mechanism. Substance use in and of itself is, excessive substance use in and of itself is pretty impulsive. And at the same time, like I said, it's almost always a coping mechanism or some type of self-medication. And Andy, I see your comment. Yes, I'll send my slides with the references to Yenting, and she can send them out to everyone, so you'll have the references for sure.
Well, we are at 1 o'clock, and I think we did manage to cover the questions that came through chat. But if there are additional questions, like I said, I will be sending an email to everyone with all 3 workshops, all the decks. If there are questions about this presentation or any of them, just feel free to reply to that email. I'll be happy to grab those answers for you. So thank you everyone for joining this afternoon. Hope you all have a wonderful weekend. Natalie, that was amazing, great information. I know we'll continue to work with you, so don't be surprised if Natalie pops up again.
Oh, I'm happy to. Thank you all so much
Yeah.
for coming. I really appreciate that you decided to give up your lunchtime to listen to me talk about not the most happy topic.
I appreciate you, Natalie, for the time and the expertise.
Of
All right,
course.
everyone. Again, expect that email from me, and we'll be in touch. Have a good weekend.
Have a
Bye-bye.
wonderful weekend, everyone. Thank you so much, Lanting.
Bye-bye.